Chapters 27, 39, and 40, Disorders of the Bladder and Lower Urinary Tract, and Female and Male Idiosyncratic Urinary Tract Disorders. So, urination begins when the bladder contains about 150 to 250 milliliters of urine. The stretch receptors in the bladder initiate the spinal reflex, and your brain gets a message that the bladder is full. Upon getting that message and getting to a restroom, the detrusor muscle of the bladder contracts and pushes the urine out. All the while, the internal sphincter and external sphincter also relaxes to facilitate what we know as urination. Here's a nice picture of the spinal innervation of the bladder and GU reflexes. This will be important to keep in mind as we study some of the neurological deficits, or as we have studied, this is one of the reasons why people with diabetes have decreased bladder stimulation, because their microvascular change to the nerve endings has occurred and made their bladder, made the sensitivity of that innervation to the bladder less sensitive. Because we go, as adults, we've gone through potty training, we know that that there is conscious control over the ability to urinate or not. And as long as the pathways and innervation is seamlessly together, we have conscious control over those processes. There's a difference in the male versus the female urethra. The female's urethra is shorter, and the male urethra is a lot longer, and it actually passes through another organ called the prostate. The prostate surrounds the urethra, and if it becomes enlarged, it will cause alterations in urination related to having a weak stream, urgency, difficulty urinating, and sometimes even a discharge, but not often. This is one of the, this is a great picture of what benign prostatic hyperplasia looks like. We know that this is due to age-related changes because of the decreasing levels of testosterone. The prostate growth grows. It's a non-malignant enlargement of the prostate most of the time, and this happens more frequently in men over the age of 60. Blacks more than whites, but rarely happens in Asians. Signs and symptoms, as we discussed before: increased urinary frequency, especially at night, with a decreased flow and what we call hesitancy, or the inability to get the flow started. For diagnostics, we do first a digital rectal exam to see how large the prostate is. The physician may do some renal studies to see that the decrease in the stream and other issues aren't related to kidney issues, so we're looking for a BUN and creatinine to come back lower versus higher. They will also run a PSA screen, which the PSA is to screen for cancer. They may also do a post-residual volume check, meaning they will ask the male to empty his bladder, and then they will do an in and out catheterization to see how much fluid is still left in the bladder being trapped there because of the enlarged prostate. An ultrasound is a non-invasive way of getting a sense of how big the size is, and a cystoscopy would be an invasive way of going up and taking a look at how big the prostate is via a scope. For the most part, initial treatment for BPH, because it is such a common thing in men and we expect it to happen with aging, is to initiate lifestyle changes. Drink less fluids before they go to bed. Make sure they're standing in order to urinate better. Avoid over-the-counter medications such as antihistamines, which may decrease the sympathetic nervous response. Secondly, we may give medications to help. Alpha blockers such as Flomax and Cardura are given to relax the muscles of the prostate and bladder to help relieve some of those I can't pee symptoms or I need to pee too much. We give 5 ARIs such as Proscar to help shrink the prostate and inhibit that growth. And they may be on PDE5 inhibitors such as Cialis and Viagra to increase the flow rate of the urine. And supplements that are over the counter would be saw palmetto is one of the major ones that you'll see, which does all of the following things, but it also thins your blood. So it's an important discussion to have with these males as they approach the need for surgery. Surgery is usually done trying to do it in the most minimally invasive way as possible. The goal of surgery is to significantly minimize the size of the prostate to improve urinary tract function. They can take a catheter like they do with the heart and insert it and minimally cut away the prostate. They can do an open reduction of the prostate, the TURP, or sometimes laser can be initiated to decrease the size. But all 3 surgeries are looking to decrease the size of the prostate. Now, these are the surgeries that are done if it is benign. Sometimes, particularly in genetic males that carry the BRCA1 and 2 genes, we see this more frequently in African Americans and those males that are from Northern America, which suggests that there's some connection with our diet or lifestyle issues, but the risk for prostate cancer greatly increases after the age of 50. Routine screening is done on males over the age of 50 or those that are at risk from having the genetic BRCA gene, and we consider a PSA level greater than 10 as highly indicative of cancer. In fact, 50% of the time it is cancer, where a level of 4 to 7 would indicate that more screening was necessary. We screen this through ultrasound, but all ultrasound is going to tell us is how large it is. The real indicator for us to understand whether this is cancer or not is to get in and do a biopsy and stage. The staging that is done with prostate cancer is something called a Gleason score, and those that have a Gleason score of 7 to 10 have fairly active prostate cancer involvement. If we find that prostate cancer is present, a subsequent bone scan or CT scan will be done to see if there has been spread outside of the prostate. Treatment is the same as for most cancers: surgery to remove the prostate and to do the biopsy and staging, radiation, hormones, and chemotherapy based on what stage the prostate cancer is in. We can have many combinations of this, with the most significant being radiation, hormone therapy, and chemotherapy. But generally, chemotherapy is not utilized with prostate cancer unless the other treatments are not working. Female cancers that we are looking at for this chapter would be cervical cancer, endometrial cancer, and ovarian cancer. Risk factors vary, but generally with endometrial cancer and ovarian cancer, there's a genetic component, the BRCA1 and 2 genes. With cervical cancer, we know that HPV infection is highly related, and we know that sometimes this happens just with a family history. Signs and symptoms include painless bleeding, generally, which is never a good sign. We diagnose this by doing physical exam, all three of them. With cervical cancer and endometrial cancer, we can do some biopsy and staging fairly easy. With cervical cancer, we do a pap smear for risk assessment. Ultrasound is utilized more in understanding ovarian cancer, but again, ovarian cancer is a very silent kind of cancer where by the time we know that something is going on, the cancer is bigger and has usually grown outside of the ovaries or into the abdominal cavity. And the first sign and symptom of ovarian cancer is most frequently pain, back pain. We may run a CA-125, and we would do this on anyone we suspected cancer of. It indicates that there has been metastasis that's gone on. Treatment for all three of these cancers are surgery, radiation, chemotherapy, and hormone therapy. They are employed solely or in combination therapy according to the stage of the biopsy and the stage of the cancer. Surgery is always the first route, mainly because of the staging that we need to take place through biopsy. Radiation is generally reserved for those instances where the cancer remains local, and chemotherapy is generally utilized for cancers that have spread. Hormone therapy may be utilized in both local and metastasis in order to keep the patient in remission for longer periods of time.